Thank you, Dr. Sindhu. Next, my topic is digital eye strain. This asset is not a workplace injury, but this has become something like a lifestyle disorder among most of the working population these days. Not only the working population, but spanning all ages, this has become a problem. But this is mostly associated with some professionals. That is why I have included this. I'll just rush through, just highlighting the points. The prevalence of digital eye strain is around 60% worldwide. That is 80% among IT professionals. And you can see that in places where people are more restrained at home, like Pakistan, it is 90%, whereas in Japan, it is only 12%. It affects all age groups. The risk factors, as you all know, is increased screen time, inappropriate viewing distance, the poor workplace ergonomics and lighting, and uncorrected refractive errors. Earlier, it was called as computer vision syndrome when people were using mainly desktops, and now the digital devices that we use has become varied and the term has become digital eye strain. At-risk population is already mentioned, IT professionals, office workers who are more at the computer, radiologists who have a fixed workstation with computers, and frequent, that is people who use mobile for a very long time at a short viewing distance because of the high accommodative demands of the small screen and short distance. When you compare the impacts between children and adults, you can see that in children it causes a progression of myopia. It was around 0.3 diopters in the pre-COVID times when digital use was less, and it became 1 diopter in the COVID times. Then recent onset esotropia, convergence anomalies, and also meibomian gland atrophy and tear film anomalies. When it comes to adults, rather than the health issues, it causes a generalized reduction in the work productivity as well as high prevalence of ocular surface disorders. Now, the pathophysiology, as you already can imagine, is mainly due to the distance related and the screen use related. So, mainly it is accommodation and convergence anomalies and tear film anomalies. Because of the prolonged use, there is a reduced blink rate, and there is a widening of the palpebral fissure because of gluing to the screen, which reduces the expression of meibomian gland as well as causes a tear film instability and high osmolality, causing ocular surface inflammation and symptoms. The symptoms are dry eye, foreign body sensation, watering, accommodation related blurring, difficulty in refocusing, ocular fatigue, and extraocular symptoms like headache, neck and back pain. So when you see a patient, you are not following any particular diagnostic criteria. We just take a history and come to a diagnosis. But there are standard questionnaires which address this problem, mentioning the symptoms, the frequency of the symptoms and the intensity, and give the score. That is a computer vision syndrome questionnaire. There are other questionnaires also like CVSS 17 and OSDI. The treatment options include therapeutic options mainly. The mainstay is lubricants. Ideally, it should be preservative free. Then if you are dealing with severe cases, you can give gels and ointments for overnight use. This can be depending on the patient, whether it is an evaporative dry eye, whether it is a lipid supplementation that is needed, or an anti-inflammatory effect. And in case of severe dry eyes, you can try short-term steroids, cyclosporin, etc. The other non-pharmacological interventions you can do is a vision therapy, especially for the convergence and accommodation related anomalies, the specific exercises. Then in presbyopes, you can give progressives with a wider intermediate zone, low plus power lenses to reduce the accommodative demand. Then in contact lens users, you can advise high water content contact lenses and also suggest environmental modifications to increase the humidity as well as give blink training, which gives more stability for the tear film. And there has been a high demand for blue filter lenses that is being promoted very much these days. But most of the studies say that there is no definite use for that. There is no change in the symptoms as well as the outcome if you give a blue filter lens. Now, the technical intervention is regarding the positioning of the screen. The monitor distance should be 50 to 70 centimeter, eye level positioning, the atmosphere changes as well as the display setting where the contrast and brightness has to be controlled, the text size, font, etc. has to be kept in mind. The scheduled breaks 20-20-20 rule you all must be familiar with. In addition to that, you can suggest micro breaks, that is take a 5-minute break every hour of continuous working, and you can tell them to consciously keep blinking at least 10 times every 20 minutes. Now the personal precautions is mainly sticking to these, use of lubricants and adequate hydration as well as the ergonomic precautions are very important. The specific guidelines there are set by AAO and WHO, that is in children less than 2 years, no screen time, absolutely no screen time except for a video call with family members. In 2 to 6 years, the maximum of 1 hour, and more than 6 years, it is only 2 to 3 hours per day with 10-minute breaks if they are using it continuously for more than 30 minutes. Schools should implement timed breaks if they are having a digital class or activity scheduled, and they should also educate the children regarding the importance of using digital discipline while using these devices. At home, the age appropriate limit should be followed. Parents should have a control over the time of use. There should be digital free zones at home, like bedroom, dining area. And also, you should have a detox day at least once in a month where they should be kept away from devices. And the area should be properly lit, positioning should be looked into, and they should have regular eye checkups. Recent studies, as I already mentioned, blue filters doesn't show much change. Artificial tears, the blink training and all are definitely found to be useful in most of the studies. So the takeaway is digital eye strain is a rising issue. We have to follow evidence-based approaches, and children require special attention. And for the future, we have to devise specific screening tools, especially integrating AI, and we should find innovations in the digital devices that we use which can make it more eye friendly, and more research has to grow into the break time parameters moving ahead from the 2020 rule. Thank you for your patient listening. Thank you all for coming over and sparing your time for this last session. Thank you once again.